Bom dia, senhoras e senhores. É com imenso prazer que a Contatti Medical recebe vocês para mais um simpósio. Esse encontro tem como objetivo ampliar o conhecimento sobre o uso do Custodiol, como também realizar um debate sobre um tema de relevância, que é a proteção do miocárdio durante cirurgias cardíacas. Eu convido para compor a nossa mesa de debate o Dr. Andrei Monteiro, cirurgião cardíaco pediátrico do Hospital Pro Criança do Rio de Janeiro e do Instituto Nacional de Cardiologia. O Dr. Juan Merria, transplantador cardíaco do serviço, transplantador cardíaco, coordenador do serviço de transplantes cardíacos do Hospital de Messejana, em Fortaleza. E o Dr. Rafael Rey, cirurgião cardíaco, coordenador de serviço de cirurgia cardíaca do Hospital Nossa Senhora da Conceição de Porto Alegre. Lembro que a participação de todos é muito importante para alcançarmos o objetivo proposto. E, desde já, agradecemos a participação de todos. Eu passo a palavra agora para o Dr. Andrei, que vai dar sequência à nossa sessão.
Bom dia a todos. Agradecer ao convite da Contatti de poder participar dessa honrosa mesa. E eu vou apresentar, então, aos senhores, Dr. Klaus Preusse. Ele é professor sênior do Departamento de Cirurgia Cardíaca de Rheins University em Bonn, na Alemanha, que vai nos falar sobre os avanços intraoperatórios, a segurança e conveniência do uso da solução de Custodiol e da solução de Nido na proteção miocárdica. Professor Preusse, please, it's a great pleasure to have you here in Rio.
Mr. Chairman, ladies and gentlemen, dear colleagues, for me it's a great pleasure to be here again in Brazil. And at first I have to thank you all for coming and to attend this symposium. And secondly, I have to thank Contatti Medical for the invitation to give the lecture about the improvements of intraoperative safety and convenience in cardiac surgery. What are the parameters of evaluation for cardioplegia in the past? It was energy, morphology, pH measurements, enzyme or trop loss, and the post-ischemic function. And today, convenience and safety. Safety is related to the patient and convenience to the surgeon. What does it mean, convenience? In pediatric cardiac surgery, in minimally invasive cardiac surgery, and in all cases with extended cross-clamp times of more than 60, 90 minutes. And what is the convenience parameter? That it means no replegia. You will not be disturbed by replegia. But the question is also, what is inconvenient? And let me start with this part first. Cardioplegia caused inconvenience. The first is the initial cardioplegic perfusion time. I know the ideal cardioplegic solution, and I will tell you what it is. That means to administer 10 ml in 10 seconds and have 10 hours of rest. That will never happen. Therefore, let us start to look what are the reasons for an extended initial cardioplegic perfusion. The first is the ongoing myocardial lymph flow. We have measured, we are the only one who have ever measured the lymph flow during cardioplegic perfusion time. And you see, even after cardiac arrest, there is a continuous lymph flow, indicating the equilibration of the extracellular space. Secondly, the equilibration of electrolytes. You see, if you use a low sodium solution, it takes about 5 minutes until the coronary venous effluent starts to plateau. Related to potassium, it is by far earlier. The next one is the reduction of energy turnover. And I'm very, very grateful to Dr. Emanuela Angeli from Bologna. She gave me these investigations. You see, she analyzed children, less than 1 month, the light blue columns, and more than 1 month old. And it is obvious, independent from the age, during cardioplegic perfusion time, the O2 consumption of the myocardium is reducing. We have also done this in younger patients, average age of 20 months and 50 years old. And you see, on principle, the same happens. During cardioplegic perfusion time, the coronary venous PO2 increases so that the difference between the inflow and effluent PO2 values are decreasing. Why is this necessary? Look, this is very interesting. If you reduce the O2 consumption, you increase the creatine phosphate content, that means the energy content of the myocardium, only due to the extended cardioplegic perfusion time. We have no evidence-based data, but we can speculate. In cases of poor left ventricular function, you may improve the energetical status of the myocardium. Whether it has any impact on the outcome, I do not know. But this is a theoretical, scientific aspect that creatine phosphate will increase only due to the increased perfusion or extended perfusion time. Finally, the homogeneous extracellular equilibration. And this is important because what we must know and what we should not forget, the intravascular and the interstitial space must be equilibrated. It is not enough only to make a washout. That means intravascular. You have also to consider the interstitial space. So I conclude. The initial cardioplegic perfusion is inconvenient. Yes, it is. However, it is necessary to enable an extended cardiac arrest only by single-shot cardioplegia, and that is the topic. What are the other parameters we have to look for? Replegia or administration of maintenance solutions. But, ladies and gentlemen, to my opinion, there is a cardioplegic paradigm, and that says we have to administer every 10 to 40 minutes. You have been trained in this way, so the old surgeon only know to replegic, nothing else. But let us look for the pathophysiological aspects of replegia. We have favorable ones and unfavorable. Firstly, the resynthesis of creatine phosphate. I will show you some data about this. The temperature will decrease, temperature of the myocardium, if it is replegic. And the pH of the myocardium is shifted towards the alkaline sides due to physicochemical reasons and to the lactate washout. Unfavorable aspects are the washout of bivalent ions and trace elements. Nobody knows which impact it has on the outcome. The loss of the sarcolemmal integrity. We have an intermittent pH shift. We have a systemic potassium loading of the circuit. And it is time wasting. And finally, I will show you data later on. It is in neonatal hearts, the replegia is harmful. And to show you some data, this is a special feature, the neonatal heart. The neonatal heart is not a small adult heart. It is completely different. And you see, potassium cardioplegia was administered to neonatal rabbits, single shot and replegia, and it is obvious the morphological impairment can be seen. Single shot is superior. And there was a wonderful study a long time ago in South Korea. They compared Del Nido, and that is a topic today too, Del Nido in rats. Ischemia, 2 hours, replegia every 40 minutes, and HDK, as I call it, Custodiol, no replegia. And they had a mitochondrial scoring, and there is no doubt. Replegia, again, seems to be harmful to the neonatal heart. Now, coming back to the adult heart. Firstly, we have to look at what happens during ischemia. Energy loss, and if you replegia, a replenishment of creatine phosphate and ATP. Interestingly, look at this. Long time ago, what we have done, we have used different anesthesiological drugs and only made the myocardium ischemic at 35 degrees. And you see, the black bars demonstrate the tolerable time for ischemia. So, anesthesia influence the outcome of the post-ischemic function. Now, if you use different solutions, again, the same. For example, this pure ischemia, this is symptomatic solution, and this is HDK. Again, whatever you administer to the myocardium, ATP will decrease. What the question is, what is with replegia? Yes, we have analyzed this. Look at this. We cross-clamped for 100 minutes, then replegia for a couple of minutes. And creatine phosphate is replenished within minutes. But ATP, it takes days, up to 4 days, 1 micromolar per gram wet weight. That is obvious. Now, again, we have to ask ourselves, why do we repleage? Now let's go, what happens during ischemia? How can during ischemia, the myocardium gains energy? It gains energy by anaerobic glycolysis. This produces, and the end product is lactate, and this leads to myocardial acidosis. And here is the crucial point. Because if you do not interrupt this process, the heart will kill itself. Then imagine. Therefore, it is very important to repleage, to avoid this extreme degree of acidosis. Because if you do not, the cell death and finally the stone heart, what Denton Cooley mentioned happens. Here you see what happens if you administer different solution to the myocardium, and this is the interstitial pH. Whatever you apply, the acidosis will occur. Secondly, you see the red dotted line. This is important for the surgeons and the anesthesiologists. The critical pH of the myocardium to resuscitate is 6.0, while with the human body, the critical pH is 7.0, 6.9. Now the question is how to combat myocardial acidosis. I have mentioned it, continuous perfusion. The old generation of perfusionists, they have been faced to this continuous perfusion. And what was the result? The result was always the same. Drama in the OR. The perfusionist combats the surgeon attacks the perfusionist attacks the anesthesiologist. It's always the same. So therefore they started, let us make a replegia every 10 to 40 minutes. Or my question is now, is there another chance? Yes, there is one. And this is called buffering, extracellular buffering. And the optimum with this would be single antegrade perfusion initially. Now, if we discuss the topic buffering, we have to look what are the suitable buffers for cardioplegia. Here you have. You see, we have hemoglobin buffer, the FAM buffer, the bicarbonate buffer, the amino acid histidine buffer, and carnosine buffer. Most probably you have never heard of carnosine. Carnosine is a double molecule of alanine plus histidine. And if you look at the pK value, the pK value is the most important parameter for buffering because that is the pH with the highest buffer efficiency. Here, 6.8, that is ideal. Therefore, we have replaced histidine by carnosine, and that is the result. You see, almost similar results, but it seems the dotted line is carnosine seems to be superior to with regard to the energy protection, energetical protection. Consequently, what must we do? We had to arrest the heart, dog hearts, big dog hearts, and cross-clamp for 5 hours, and then we repleaged. Oh, no, sorry, not repleaged, we reperfused. And this is the result. Look at this. A complete destruction of the cellular structures, the myofibrils destroyed, extreme edema, and this is histidine. There is edema, there is some mitochondrial crystallisis, but better, by far better condition. So in 1987, a study on buffering power was published, and they compared bicarbonate and THAM, always the best, always the same efficient buffering power of both. And what is with histidine? If you compare 15 or minus 15, 16 versus minus 60 millimolar, so that is by far superior. So we can conclude THAM is not good. Bicarbonate we can forget. Carnosine the same. And histidine is the remaining buffer we should use. The efficiency of a buffer depends on the feature of the buffer, as demonstrated before, and on its concentration. And here is another crucial point, because the limiting parameter is osmolarity. You see, 300 millimosmol. What does it mean? I tell you, very simple. Look, if you have, this is the total osmolarity. And if you have a low sodium solution, you have an osmotic space to add a highly concentrated buffer. In comparison to a high sodium concentrated solution, there is no space to add a highly concentrated buffer. Therefore, we conclude only low sodium solutions offer the opportunity to add a highly concentrated buffer. To give a further example, if we compare St. Thomas's solution and HDK solution and only focus on sodium chloride, you see, 15 millimolar versus 160 millimolar. And the appropriate osmolarity is 30 versus 230. And what is the problem? As already mentioned, the upper limit of osmolarity. This is 300 milliosmol. All you have used, or you are using HDK solution, no, this is the composition of the solution. And if we now look at the pH, what happens during ischemia, this is St. Thomas's, this is potassium arrest. And this is Custodiol. And here is the difference between these two. Now, you may argue, this is interesting, that is the buffer effect. No, because what you should consider, it may happen that these hearts produce more lactate at the same time. What must we do? We have to compare the equivalent lactate contents at the same pH. And you see, acidosis causes myocardial ischemia. Ischemia is deleterious, and high buffer capacity decelerates the ischemic injury. But how to prove the efficiency? Very simple. We measured the pH at the same lactate content. And here you see 0 histidine. This is 100 millimolar, and this is 180 millimolar. And it is obvious, the higher the potassium, the higher the histidine concentration is, the higher the buffer capacity, the more is this curve shifted towards the alkaline side. And now let's look for comparison, St. Thomas's or potassium versus Custodiol. And now it is obvious that this is the buffer effect. Even at low temperature, this critical limit of resuscitation will not be reached. Now, with special regard to Del Nido, for the first time in this lecture, we have used Custodiol solution, as mentioned before, 180 millimolar, and then, ladies and gentlemen, we added procaine. And look what happens. This curve is shifted towards the alkaline side. What does it mean? That means if you use lidocaine or procaine, the total buffer capacity being available cannot be used because the permeation of the membrane is disturbed. Therefore, lidocaine, procaine is perfect to rest the heart, but later on, it is not as good as people think. So, let's summarize. The efficiency of a buffer depends, firstly, on the chemical properties of the buffer concentration, for sure, of the buffer solubility, the membrane permeability, and the organ-specific and systemic biotolerability. I will only give some words on the solubility. It may happen to you by accident that anyone has put a bottle in the fridge, deep temperature, and the next morning you see some white powder at the bottom. There's only one chance. Throw it away. Because in this case, the limit of solubility has been reached. Okay, now let's look for morphology. At 15 degrees of centigrade, pure cross-clamp, symptomasis, the potassium arrest, and 240 minutes of Custodiol, and it's obvious even after 240 minutes of cross-clamp without replegia, we have superior results in comparison to 2 hours of arrest with potassium. Some other, the endothelial mitochondria have been evaluated. And you see, 10 is poor, 0 is good. Even after 300 minutes, the degree of injury of the endothelial mitochondria are by far superior to potassium and pure ischemia. And the same, on principle, happens with the edema, mitochondrial edema and endothelial edema. You see, Custodiol HDK is superior after 250 minutes in comparison to 150 with potassium arrest and 27 minutes of pure ischemia. Okay, these are now our recommendations for the administration. We prefer antegrade cardioplegia. Whatever you prefer, two-stage or bicable cannulation. The amount of volume, as mentioned initially, remember the extended cardioplegic perfusion time, and 6 to 8 minutes. In transplantation, you should or you must increase the volume. 3.5 liters seems to be optimal. 10 minutes, and the temperature should be less than 5 degrees. But the big advantage is only single initial perfusion. That means single shot cardioplegia after up to 3 hours. Can I prove, I have looked for a long time, how can I demonstrate the necessity of extended cardioplegic perfusion? Yes, I used harmonic imaging echocardiography. And look at this. After 6 minutes of perfusion, there are some areas that are not equilibrated. This is a lady, 64 years old, or was a lady, severe hypertrophy of the left ventricle due to aortic stenosis. Let us speculate. It has happened to everyone that you had done a perfect operation. You think you have done a wonderful cardioplegia, whatever, and you have problems to come off bypass. To my opinion, this is the reason. We think equilibration is good, protection is good, but we are wrong. What is the conclusion to draw from these data? Very simple. The equilibration processes are volume, but mainly time-related. So, the big advantage of Custodiol is no plegic reperfusion necessary up to 3 hours of cardiac arrest. These are the data for the neonatal heart. To be honest, I had a very fruitful discussion with Maina from Contatti Medical. We spoke about the amount of volume being to administer in dependence of life, of age. In the first months, you should administer 50 ml per kilogram. In the second months to 1 year, 30, and finally 20. Why? Why is it so that 50 ml must be administered initially? Because, very simple, the coronary resistance of the neonatal heart is so low that you have to administer more than the 20 ml per kilogram later on. Perfusion time can be shorter. But reperfusions are harmful, and therefore reperfusion should be avoided. And these are some data or some references you should look at. Now, let's move to some clinical data. A wonderful study being presented 2 years ago in Florida. They compared 159 patients with single-shot cardioplegia versus blood cardioplegia. It is obvious that it was time-saving. Secondly, all other data are equivalent. Without one data, I have no idea why it happens. The survival rate was highly significantly shorter in the blood cardioplegic group. Interestingly, in Germany, there was a paper being published. The same happens after mitral valve resurgery, and you see, in blood cardioplegia, after 3 years, more patients have died than in the Custodiol group. Again, these data shown before, and to continue, these groups, there were significantly less post-operative problems with HDK solution due to gastrointestinal complications, new pacemaker implantations, and dialysis. A big study from Leipzig, 2,700 patients, low output syndrome only in 1.4%, mitral valve surgery, and you see the 5-year survival rate was perfect. In hospital mortality only 1.2%, single shot cardioplegia. Another paper from Italy comparing Custodiol versus blood cardioplegia. No replege in this group. They repleged every 20 to 30 minutes in the blood cardioplegic group. It is interestingly that the troponin I loss after the first day was significantly higher in the blood cardioplegic group. Dr. Angeli from Bologna gave me this data. She demonstrated, she used in arterial switch operations HDK solution. She did not replege. Cross-clamp time was 95 minutes. And defibrillation, spontaneous defibrillation in 100%. And please let me stop for a moment to this special aspect, defibrillation. LV defibrillation after aortic declamping. If you look into the literature worldwide, either they have low incidence or high incidence. But how can it be? This is my hypothesis. We have worldwide similar patients, adults, neonates, similar procedures, valve implantations, aortic arch replacement, whatever. The same solution. What is different? Different is the anesthesiological protocol. That differs from hospital to hospital. That is without any value. I only give you an idea why there are such differences between fibrillation, low incidence or high incidence. Now, coming back to the clinical data. In Beijing, they did a wonderful study in newborns, potassium arrest versus HDK. You see, they could save time because they did not replete. And the result, mortality was lower in this group, and the CK loss at the second post-operative day was significantly lower as well. A study from Russia. They operated on patients, on babies, 7.6 hours of life. And you see, after 12 hours, their lactate level returned to normal. Cross-clamp time was 0, no replete. Now, what is with low ejection fraction? We analyzed this, especially this group, valve replacement plus minus cabbage. Average age was 69 years, 32. These are the data. Temperature was 8 to 10 degrees, 6.9 because low ejection fraction to improve the myocardial function. Perfusion pressure, that was the amount of volume. And you see, reperfusions were necessary in about a little bit more than 10%. And the mortality was decisively lower in this group, in our group with HDK in comparison to blood cardioplegia. And unpublished data, still unpublished data from US, from the Detroit, and they looked what happens with the ejection fraction intraoperatively. Interestingly, this is for the first time that it could be demonstrated that the ejection fraction was highly significantly superior in this group versus the standard group, although cross-clamp time was the same. Now, before I come to Del Nido, financial aspects. It was published last year from America. It was a single institution retrospective case control review, Custodiol versus blood cardioplegia, 181 in each group. And they could demonstrate, less blood transfusion, less stroke, less readmitted to hospital, and the hospital charge, interestingly, they could save altogether, after the whole stay at the hospital, about $3,000 per patient. Now, coming to Del Nido. You see, Del Nido was used versus Custodiol. Interestingly, this is a typical sign for me. This is a cardioplegic paradigm. They repleged, although it was not necessary, after 40 minutes, and they repleged after, it was Del Nido after 44 minutes. The same, there's no need for. It's another study from comparing Del Nido versus blood cardioplegia, Buckberg's, you see in-hospital mortality was slightly higher. Cost doses was less, for sure. Defibrillation happens more often in the blood cardioplegia, significantly more. Now, due to the current situation with Del Nido, we have started to do animal experiments, piglet hearts, neonatal piglet hearts, and the piglets had an age of 3 to 4 days. We used either Custodiol, HEK solution, or Del Nido. And now, ladies and gentlemen, please be so kind to follow me. We used plasma light, as Dr. Del Nido mentioned. If anyone uses ringolactate or something others, there's no evidence-based. We do not know, and there are no experimental data. What happens if we replace plasma light by Ringer's lactate? Be cautious. Nobody knows. Now, again, I mentioned already the influence of procaine. Remember, lidocaine, procaine, only to remind you to this special aspect. We have focused on electron microscopic data. This is Del Nido after 60 minutes. This is HDK. There is no difference, to be fair. And what happens after 220 minutes? You see some disruptions of the myofibrils, edema, crystallizes, and it is obvious that with HDK solution, superior results. Now it is quite clear and very fair if you argue, perhaps you have only looked for the very poor specimen and compared it with the best of HDK. Therefore, what have we done? We made a so-called electron microscopic map. That means 4 times 4 images. And this is the result after 120 minutes with Del Nido. Again, edema, disruption of myofibrils versus Custodiol. There is some edema, yes, there are some crystallizes, but the myofibrils seem to be in a very good condition. Now, we have increased the time of ischemia without repleach, looking for Del Nido. And the first experiment, 3 experiments, after 3 hours, severe edema seemed to look good. Second experiment, drama, and this was the final one, the third one, a complete destruction. And these, I tell you, these hearts will never recover and will not function. We put an LME, a map again, and here you see 2 different maps. It is obvious. It failed completely. And what is with Custodiol, with HEK? After 3 hours, edema, some crystallizes, but the myofibrils seem to be in a good condition. Second one, again, the Z lines perfect, crystallizes, edema, but myofibrils perfect. And finally, this is the third experiment. Please, these points, these artificial effects of the electron microscopic investigations. And again, I have shown this data, this slide. Del Nido, 180 minutes, 4 times 4 images. And what is with fair question, what is with HDK solution? And look at this, perfect. Edema, quite clear, but you see the Z lines in a perfect conditions, not contracted. Well done. So, related to neonatal myocardial protection, the following conclusion can be drawn. If you prefer, some do it, okay, hypothermic intermittent cross-clamping, you have a safe cross-clamp time of about 20 minutes. If you use Buchberg's quadriplegia, you have a safe cross-clamp time of more than 30 minutes. St. Thomas's or potassium, you have a safe cross-clamp time of, again, 40 minutes. Del Nido, for sure, 60 minutes. Plasma light has been used. And Custodiol, for sure, 60 minutes. And what is, with Del Nido, longer than 60 minutes? 90 minutes, okay. And with HDK solution, safe 3 hours. Not only in neonate, but also in adults. That is the fact. So I come to the end. Single shot cardioplegia combined with extended cross-clamp leads to time lapse and convenience. Intraoperative safety and convenience by single shot cardioplegia are only possible if a highly buffered cardioplegic solution is administered. High buffering power in a cardioplegic solution can only be realized by an intracellular type, that means low sodium. And HDK solution is the only highly buffered cardioplegic solution available worldwide by which cross-clamp time of 3 hours is feasible without replegia, independent from patient's age and gender. And therewith, safety and convenience are improved. I thank you very much for your attention.
Thank you, Dr. Preusse. Gostaria de abrir para a plateia perguntas para o professor Preusse e para os colegas da mesa também.
Sorry.
Dr. Klaus.
One or two?
Three.
Now a little bit, yes. Can you hear me? Oh, sorry, for a moment. Perhaps you can...
What temperature you cross-clamp
the temperature we cross-clamp is normally 34 degrees. In cases of arterial switch, aortic replacement or arch replacement, we lower the temperature to about 22. I tell you, my good friend Roberto Di Bartolomei from Bologna recommends only 26, and he exclusively uses this solution.
Quem quiser fazer perguntas em português para o professor Preusse, ele está com um tradutor, fiquem todos à vontade.
Please, when you go back on pump, when you have a situation that you should redo your surgery, what can we do?
Thank you very, very much for these important questions. You will find no literature about this, no references. We have analyzed 60 patients in which we were forced to go on restart bypass due to bleedings or an incompetent mitral valve and so on. So if you have once weaned from bypass and restart, then please follow the same protocol as the initial application. if you, and that is for all, if you replegic during an operation, please only, if for sometimes it is necessary, longer than 3 hours, then replegic for 2 minutes, that means about 400 ml, that's it.
I have one question. In a special situation, in a transplant, if you have more than 3 hours for ischemic time, do you think that you have to repeat on the table or not?
No. In transplantation, we have a different situation. Transplantation, we have a safe arrest of 5 hours. 3 hours intraoperative, 5 hours. What? If this time will be exceeded, then I would recommend to replegic 200, 400 ml before you start implanting the heart.
Eu gostaria de ouvir também a experiência dos colegas que compartilham essa mesa. Dr. Juan, uma das maiores experiências em transplante no cenário nacional, e eu sei que no início da experiência nós não tínhamos aqui disponível o Custodiol para utilizarmos nos nossos transplantes, e queria ouvir a sua experiência, se você notou alguma diferença, além da comodidade, o que é que vocês faziam antes, como vocês fazem hoje. Queria que você falasse um pouco da sua experiência inicial e se você notou alguma diferença para o cenário atual em termos de preservação.
Obrigado por o convite para estar aqui. Recentemente, antes de responder e fazer esse comentário que o André está solicitando, uma situação similar aconteceu em Fortaleza. Fortaleza não chovia há uns 5 anos atrás, a maior seca que se viu nos últimos tempos, e começou a chover este ano, né, para a alegria do governo do Estado. E nós fizemos uma retirada à distância em Natal, um voo muito curto realmente, mas quando o avião voltou com os colegas que haviam retirado o coração, eles não conseguiam pousar no aeroporto pela chuva. E nós já com o paciente aberto, preparado, porque sempre calculamos normalmente quanto é a distância entre o aeroporto e quanto sai do aeroporto para o outro. Enfim, nós sempre calculamos e dá certo. 15 minutos não conseguia pousar, 20 minutos não conseguia pousar, com 30 minutos avisaram que o combustível do aviãozinho estava acabando. Com 40 minutos alguém falou que o pontinho no radar do avião havia desaparecido. Nessa hora todo mundo ficou nervoso no centro cirúrgico. Começaram a fazer comentários que o nome do serviço de transplante do Hospital de Messejana levaria o nome já do colega que havia ido a retirar o coração, que uma UPA, Unidade de Pronto Atendimento, levaria o nome da enfermeira, coitada, que estava lá, e que um programa da saúde e família do interior ia ser o nome do técnico, que é um instrumentador que leva as coisas. Com 45 minutos, parece que o piloto liberou o pessoal para que entrasse em contato com o pessoal, nós, que estávamos esperando o coração desesperado, né? E aí uma enfermeira, acho que não foi muito inteligente, pediu para o doutor que estava, para o Fernando Mesquita, que estava havia tirado o coração, disse: você teria alguma coisa a dizer como último depoimento? Por último, felizmente conseguiram pousar, mas aí entra o que o André acabou de dizer, né? E de perguntar. Chegou com 3 horas de isquemia para uma coisa que era de Natal e do lado de Fortaleza, mas eram 3 horas. 3 hours ischemic time from a city near Fortaleza, but the flying around the airport without any condition of landing, okay?
Yeah.
Então, aí nunca havia acontecido conosco essa situação, porque sempre os transplantes dentro da cidade, aquela coisa, sem problema, média de tempo de isquemia 120 minutos, né? Com o transporte e tudo. E aí ficou essa dúvida realmente, Andrei, né? We have to do the replegia with the Custodiol. All the volume?
No.
or just, as you said, just 250 milliliters. Nós fazíamos todo o volume que está calculado de início, na hora que foi retirado o coração, ou se fazia unicamente, como o professor acabou de dizer, que just 250, ok?
Yes.
Bom, nós fizemos 1 litro a mais, né? E o diretor não ficou muito contente depois com a conta do Custodiol. Mas deu certo, felizmente, o paciente mais, para que vocês observem como cada situação realmente tem que se ajustar às características. I have a question, Professor. Eu vou falar em português para to make easier. I will speak in Portuguese to make easier the understanding of the people. Okay? A metade das suas conferências são relacionadas com gráficos físico-químicos de situações intracelulares, intersticiais. E nós entendemos que o pH do interstício intracelular é muito importante para que as coisas funcionem. Tem que ter uma temperatura adequada, para ter uma viscosidade adequada, para ter uma osmolaridade adequada, para que o buffer, que é o ponto central, funcione. Ok? Quando o cirurgião está operando uma cirurgia geralmente longa, ele quer terminar e já vai aquecendo o paciente uns 20 ou 30 minutos. Aí tem os perfusionistas que não me deixam mentir, correto? Vai aquecendo enquanto vamos terminando a cirurgia. Mas isso aí está destruindo o equilíbrio que nós tínhamos conseguido inicialmente, o que está preconizado pelo fabricante e pelas condições da bula para utilizar o HTK, o HTK. Como seria o correto no rewarming, no reaquecimento? Só nos últimos, faltando muito pouco para terminar a cirurgia? Ou está permitido meia hora antes, dependendo do oxinador, da membrana, o circuito que você tem, para poder terminar a cirurgia com que temperatura para evitar esses conflitos físico-químicos?
Thank you very much, Dr. Mejia, for this interesting question. At first, I may give a simple statement. The more ineffective a solution is, the lower must be the temperature. The more effective it is, the higher can be the temperature for the myocardium, even for the retrocardial areas. Therefore, if you have, for example, a valve 60 minutes procedure, whatever, I think you can start with rewarming after 30 minutes. So when you finish your last stitch, the body's temperature may be normal. You should, except the extended cross-clamp period, extended, that means more than 3 hours. In all other cases, don't care about this. Don't care about temperature. And there is one special aspect. The higher the degree of acidosis, the less is the incidence of post-declamping fibrillation, because acidosis protects against these dysrhythmias.
Really?
Really, because we know if you use this solution, for example, for short cross-clamp period, 30 minutes, I promise you will have almost a 100% fibrillation. But all who are experienced with the solution, they report that cross-clamp time more than 2.5 hours. They declamp and it runs without any problems, without defibrillation. It is interesting. It's a fact.
Doctor,
sorry.
And
Actually-
okay.
Oh, sorry, doctor.
Os que queiram fazer alguma pergunta da plateia, por favor, tem um microfone, podem fazer uma fila aí até.
Como o senhor falou, na experiência do nosso serviço, quando nós começamos a utilizar o Custodiol, a gente só volta ao reaquecimento nos casos de hipotermia profunda. Se for hipotermia moderada, espera a reabertura da aorta para começar a aquecer. Justamente a gente tinha essa dúvida em relação à interferência da temperatura no efeito do Custodiol. Então, a gente realmente não aquece. Ao contrário do que o senhor falou para nós.
The same, né? Okay.
Yeah, to be honest, this is let me say, a learning effect. Not to look at the temperature, not to look at replegia. So, indeed, the old surgeons are trained and perfusionists are trained. Temperature, play, and cross-clamp time up to 3 hours play no longer any significant role.
Dr. Preusse, parabéns pela apresentação. Eu vou fazer 2 perguntas. Uma delas que eu acho que ajuda a esclarecer algumas dúvidas que colegas que tentaram utilizar o Custodiol, porque eu uso 100% dos meus casos congênitos, mas colegas que tentaram usar e não tiveram bons resultados, ao desclampear a aorta, o coração não estava bem protegido e não ficou com boa contratilidade, normalmente questionam que esse coração volta a bater várias vezes durante a cirurgia. Ou seja, feita a proteção, o coração ficou em repouso, depois ele voltou a bater. Quem faz cirurgia de congênita sabe que isso é um problema, muitas vezes, pela questão de retorno de sangue no átrio esquerdo, você não conseguir aspirar, aquilo reperfunde coronária, então é necessário realmente repetir as doses. A última discussão que nós tivemos, que nós conversamos, acho que foi lá em Belo Horizonte, e eu passei a fazer realmente 1 minuto para parar de bater e voltar a operar. Só que eu tive um caso recente onde isso voltava a cada 20 minutos, ele voltava a bater, estava muito difícil de a gente evitar. O quanto que é ruim ficar fazendo várias reperfusões, várias replegias, né? novas volumes de Custodiol, e quanto que a gente pode esperar? O que seria seguro em termos de atividade elétrica já deveria ser abolida, ou a gente tem que esperar realmente contratilidade do músculo? Às vezes a gente vê já uma atividade elétrica e alguma contratilidade do átrio, mas não do ventrículo. Então a gente teria uma segurança de esperar até o ventrículo começar a contrair, para não ter que ficar fazendo replegias.
Yeah. Well, thanks. Very interesting, and I should have mentioned it. I apologize. Worldwide, surgeons report that activities on the screen occur 20 to maximally 30 minutes after clamping of the aorta. There was a study in 1982, experimental study, dogs, and 5 dogs were treated with HDK. 3 of them started to fibrillate after 15 minutes. 2 starts to fibrillate and one starts to beat. They did not care because that was the experimental protocol. And all 5 dogs could be weaned from bypass. This is a secret. It never happens after 35, 40 minutes, never. We do not know what is the reason. What are the reasons for these activities, mostly on the screen? Mostly. Therefore, I always ask my perfusionist, please remind me after 5 minutes. Let it fibrillate or beat, whatever. If it will not stop, then replegic. And this happens in 10% of the cases. Nobody knows. Atrial fibrillation, please do not care about this. Ventricular fibrillation is a quite different thing. So that is my recommendation. In this special case, I'm sorry, I have no idea. I know a case from being presented in Egypt, in Cairo, some weeks ago, and they asked me, and I asked them, did this child had a upper left cable vein? That is the first question I would ask.
And it's a problem because sometimes you have this kind of things, and you should be care about that. Another question is about the reperfusion.
Yeah.
In childhood, I used to let the pressure down like 20 to 30, the median pressure, for 2 minutes. Is it really necessary, or I can take off the cross clamp and go to the right pressure, like 40 or 50?
There are no clinical evidence data, but what I know from the literature, there was a wonderful study a long time ago. They started at 20-30 millimeters of mercury after declamping, and then they slightly increased. And this special group had the best recovery in comparison to that one, that in whom, or the group in which the cross clamp, it was declamped and high pressure. So let it slightly increase.
For child and adults?
For child. Yeah. In adults, don't care about this. Yeah.
Thank you.
Thank you.
In an old presentation you did, you mentioned that before infusing the Custodiol, the HTK, you have to suck to collapse the aortic root. Is correct?
Perfect.
Is it necessary, really?
Yeah. Because.
Could you explain this?
Yeah. Because, look, from the energetical aspect, the most critical layers of the left ventricle are the endocardial ones. Therefore, if you have sucked off or sucked the aortic root and it collapsed, that means the left ventricle is also emptied. And if you start the perfusion, you can be more or less sure that these subendocardial layers, these critical layers, are well protected.
Cíntia Chalegre, quero perguntar, está nervosa, hein? Por favor, professor.
Dr. Klaus, em cirurgias menores de 90 minutos, o senhor vê alguma vantagem no uso do Custodiol ou não vê vantagem nenhuma?
In cases of, you mentioned 90 minutes. Let me say in cases of 30 to 40 minutes, to be honest, it is not harmful. You can use it. But it depends on the surgeon. And please forgive me, I always joke and argue up to 60 minutes, the human heart tolerates a lot of surgeons. Yeah? Okay, so 60 minutes. For example, in cabbage, makes no sense, surgeons are so fast. But you can use this for protection of vein grafts. That is very efficient. We have done this. We have analyzed human vein grafts and measured again the pH at the endothelial surface, it was superior, and even the morphology was superior. So we should not underestimate the metabolic rate of the vein grafts. We all think the vein graft, oh, forget this, what is it? It's nothing special. No, be cautious. This is very often have a relatively high, unexpected metabolic rate. Yeah, only for vein. But for short cross-clamp time, you can use it, but there's not, I will not say a must. Yeah.
Quando cirurgião tem que operar uma paciente com estenosis, quando cirurgião tem que operar paciente, uma estenose aórtica com uma função ventricular muito comprometida, deteriorada, já entra com muito receio do resultado da cirurgia e tenta proteger ao máximo esse miocárdio. Em todas as suas publicações e apresentações, o senhor, professor Klaus Preusse, você não recomenda aquela carga de cardioplegia por via retrógrada que muitos de nós costumamos fazer. Nos explique por quê, por favor.
Thanks, Dr. Mejia. Yes, because I am not a favorite for retrograde protection, because it is an anatomical fact that only 70% of the coronary venous blood drains into the sinus. That means if you administer the solution retrogradely, you will not reach the total heart. And what part of the heart will not be reached sufficiently? The right ventricle. And we all know the right ventricle, if this failed, it is a drama, it is a problem. Therefore, in such special cases, I would recommend to increase the initial perfusion time. The volume might be 2 liters, but increase up to 8 to 10 minutes. That's what I would recommend, to guarantee a homogeneous equilibration of both right and left ventricle.
Even in adults and newborns, infants, is important you suck off the custodiol, or it depends? Do you think that is a rule, suck off or not?
I tell you, I think there is no doubt in neonates it should be, because mostly the neonates are venous. Can you have a venous bicable cannulation? You should suck it off, because the volume loading should be avoided. In adults, if you have a mitral valve, you have mostly bicables. If you have a two-stage cannula, then we recommend to integrate a hemofilter into the extracorporeal circuit. That is a fact. It is, well, the only thing is hemodilution, and this it depends from patient to patient. It may reduce the peripheral resistance. Yeah, but you can, with some amount of small amounts of inotropes, you can counteract. But neonates, no, avoid it, never. In adults, whatever you prefer. And it depends on the perfusionist. Some perfusionists argue, there's no problem for me, and some say, well, it's better to have a hemofilter. So that's my answer to this question.
Nos casos, vou falar em português. Nos casos onde a gente tem insuficiência aórtica, também são casos onde algumas vezes a gente não consegue fazer de forma anterógrada adequada. E diminuir a velocidade de infusão, às vezes até piora, porque você não consegue armar, e isso é uma coisa que eu sempre falo para os meus residentes e assistentes, que a raiz da aorta tem que estar armada para ter certeza que está perfundindo, já que eu vou fazer só uma dose, não vou fazer várias doses, essa dose precisa ser bem feita. Nos casos de insuficiência aórtica, uma opção seria fazer a forma retrógrada. Eu faço em alguns casos, faço um pouco anterógrada, um pouco retrógrada. Não é que existe uma coisa ruim de fazer retrógrada, a questão só é o fato de que pode não estar sendo protegido o ventrículo direito, seria isso? Não existe um problema em se fazer o custodiol de forma retrógrada, é mais uma questão de não atingir toda a musculatura do coração, seria isso?
Completely agree what you mentioned, completely. And what I do in my severe, even in severest, in severe mitral insufficiency, degree 3 to 4. I always start with integrate. And if the heart will not stop within 2 to 3 minutes, then I stop the perfusion, dissect the aortic root, and continue with isolated left coronary perfusion only, because if there is no coronary heart disease, you realize if you only perfuse the left coronary artery, after 1 to 2 minutes, that the solution runs out of the right coronary orifice. Therefore, there is no need to make a double coronary perfusion. Right coronary perfusion, left coronary perfusion. If the heart even will not stop, even then stop the left coronary perfusion, perfuse the right for 1 to 2 minutes, and then continue for 2 more minutes the left. Again, retrograde perfusion is not harmful, except you should keep in mind viscosity is only half of blood cardioplegia, pressure must be halved, 20 to 30 millimeters. But if people favor only retrograde, they should always keep in mind the right ventricle will not be protected as they think or they wish to have.
Mais alguma pergunta? Would you like to do any final consideration?
Well, I really appreciate it to always to be in Brazil and to join you. And whenever, please, whenever you have in your hospital a question or a problem, please do not hesitate to immediately contact me personally or Contatti, Jefferson, because I guarantee we solve the problem. And even if it is necessary to visit you, it's no problem. This is my finding, and I thank you. I thank you very much for your kind hospitality. Thank you.
Thank you.